Good morning. We're going to talk a little bit now about the critical injury across the lifespan. And this is going to be a little bit different because it's going to be really short. It's not going to spend a lot of time on this. But what we're going to do is we're going to put together all of those pieces that you've been learning through the critical care course. And we're going to do kind of like a case study. And we're going to compare the injury patterns from a pediatric patient to a geriatric patient, and just seeing the differences and how you have to approach these patients a little bit differently and take into some considerations. So I'm going to make you start to think on a different level, okay? So you have your PowerPoints in front of you, and basically the pediatric geriatric difference is quite obvious, right? American College of Surgeons, who is what credentials us as a trauma center, says pediatrics is 15 years of age and younger. So even though we treat 16 and 17-year-olds as pediatric patients, and they are, and it really is weight-based, right? So some of them are big kids, and the 15-year-old or even a 14-year-old could be the same weight as an adult, and we would treat them as far as medications go with adult dosages. And versus geriatrics, who would be 65 years of age and older, sometimes are really tiny, and we may need to consider smaller doses, not an adult dose, for those types of patients because they're so small and tiny. So just something to keep in the back of your mind. There's old versus very old. So your old would be like 65 to 75, and then your very old would be older than that. As your body ages, it doesn't, do well. It begins to, deteriorate, if you will. We're not meant to live forever. And unfortunately, over 80 years old, you start to look like that sometimes. But you have that chronological age versus biological age. So biological age would be basically the natural process of aging. Just as you get older, you have people who biologically look great. They could be 85 years old, but they look like they're 60, and then you got people who are 55 that look like they're about 90. But that's just, basically disease processes that come into play and just lifestyles. And then your chronological age is basically just your age in years, okay? So the most common injuries that we find in pediatrics are accidental injuries. And with geriatrics, the most common over the age of 65 would be falls. And then the greater the age, the greater the risk as far as injury goes and recovery time, okay? So generally speaking, a trauma patient from beginning to end, from point of injury to full recovery, is generally about a year if they're really critically injured. That's a long time. It's more than families realize. And when patients are critically injured like that, that's a good conversation to have with them, to say this isn't going to happen overnight. It's not like surgery and in a few weeks to a couple of months you're back on your feet again. It's a long rehab, and sometimes not recoverable either. Sometimes they go through the process and they just don't do well, and we end up withdrawing care. So let's start with our first case study. All right, we're going to do one case study. We're going to go through this together, and we're going to compare some injuries. All right, so you've received report of 2 patients coming to your trauma center from a motor vehicle crash. All right, the report begins with a family of 4 that was driving home from the movies. They were involved in a high-speed head-on collision with another vehicle. Patient A is 40-year-old male. He was the restrained driver. Patient B is 35-year-old female. She was a restrained front seat passenger. Patient C is a 5-year-old female. She was partially restrained in the rear seat. That would be a lap belt only. Patient D is a 78-year-old male who was partially restrained in the rear seat also, which would be a lap belt only. So my question for you is, do you have any questions about the report so far? Is there something that you would like to know? Any questions that you have? So maybe you want to know, what does their presentation look like? Which patients am I getting? Give me a little bit more of a story besides that, right? Medical history, what do they look like now? What is the assessment that they're finding pre-hospital, right? So which 2 patients do you think you're going to get based on what you know so far? So based on just that and a little bit of information, which 2 patients do you think are coming to you as the trauma center? And why do you think that? So based on what you know so far, you're probably going to get the 5-year-old and you're probably going to get the 78-year-old. Now, besides the fact that we're doing a pediatric and a geriatric case study, that kind of gave it away. But just think about, they were lap belted only. Without the shoulder restraint, that's a big high injury. We talked about abdominal trauma, knowing that those lap belts are very dangerous if you don't wear your seatbelt correctly. So we're going to get those two patients. We're going to get the 5-year-old, and we are going to get the 78-year-old. Okay. Or the 76-year-old, sorry. Okay, so pre-hospital considerations. What are we going to think about here? So the mechanism of injury. Remember, we talked about mechanism of injury lots of times before. One of the things I don't think I've mentioned to you is about the different types of crashes there are. So basically, there are potentially 4 crashes when we talk about a mechanism of injury for a car crash. So there's 4 crashes. The first crash would be if the vehicle is moving at 50 miles an hour and the vehicle crashes, the vehicle then stops. Okay, so that's the first crash. The second crash would be you as the passenger in the car continues to travel at 50 miles an hour until you stop. Okay, so that's where the seatbelts and the airbags come into play to try to slow us down. It's not the speed that kills us, it's the deceleration that kills us and that injures us. We need to slow down the deceleration. We need to figure out how to disperse the energy so that it doesn't impact the body as much. It lessens the injury when we can disperse the energy. So that's why cars are meant to crumple up like a ball. That's why we have such big front ends. They crumple, they disperse that energy. It makes that deceleration less harmful to the occupant inside the vehicle. Okay, so crash number 1, the car stops from 50 miles an hour. Crash number 2, the body stops. Crash number 3 would be the organs inside the body. They have to stop at some point too, because they're going to continue traveling at 50 miles an hour until they stop. That's where they crash into the rib cage. That's where there's points of they tear. You know, when I talked about the ligaments and the structures that hold our organs in place, that's where they tear, is that third impact. Okay, so what's the 4th impact? What do you think might be a 4th impact? That would be anything else in the car that's not nailed down. So it could be a person that's unrestrained. They could be another object. And that everything in that car is going to be traveling at 50 miles an hour until it stops. So it's all coming forward. So if my purse was sitting on the front seat, as heavy as that is, it'd probably go right through the windshield. So think about the things that you might have in your car right now. If you were to crash at 50 miles an hour, what would come from behind and hit you from behind? This is where we find those weird injuries that don't make any sense. Like, how did they get hit in the back? How the hell has scalp lack in the back of the head? Maybe something from behind the back of the car hit them in the back of the head. So you have to kind of put all those puzzle pieces together. So there's potentially 4 crashes in a car crash. All right, just kind of wanted to throw that out there to you also. All right, so our mechanism of injury. What are our real and potential injuries? What's our past medical history? That's a big deal. Past surgical history, what medications are they on? And what do our vital signs look like right now? That's all really important information. But let's just say, for argument's sake, it's at high rate of speed. Okay, so let's go with 70 miles an hour. And the car crashed into another vehicle, head-on collision. Okay, the 2 patients that we're getting is a 5-year-old and a 76-year-old. Both of them lap belts only. They crashed. What type of injuries would you suspect that they would have? I'll give you a couple minutes. I want you to write down what all the different types of injuries you think the 5-year-old's going to have and you think the 76-year-old's going to have. Okay, so let's talk about what injuries you suspect these patients might have. Okay, so let's talk about the 5-year-old. What kind of injuries could a 5-year-old have? Lap belt only. Concussions, skull fracture. You're thinking about them bending in half. Okay, what are they hitting in front of them? Are they close enough to the seat? Are they restrained well enough? Did they hit the seat in front of them? Could they have spine injuries? Could they have spinal cord injury? Gastric injuries. Today we talked about the abdominal compartment syndrome and the belly injuries. Gastric injuries, small bowel injuries, large bowel injuries, liver, spleen, pancreas, all of those organs could potentially be injured as well. maybe even a bladder injury. What about the 78-year-old? Subdurals, epidurals, any head injuries, spinal cord injuries. Their bones are not as good as, not as flexible as a child would be. So they also could have abdominal injuries as well. Same thing, gastric injuries. They could have, small bowel, large bowel, liver, spleen, pancreas, bladder, who knows, rib fractures. They could also have pneumos, a hemopneumo. I worry about spine injuries and spinal cord injuries with the elderly too, because this man who was in this back seat with the child is taller than the child. So chances of them hitting the front seat and even doing like a flexion extension type of injury is possible because of, them hitting that seat in front of them. Okay, so good job. So let's talk about how do we do our primary assessment, the ABCDE assessment of these patients. Okay, we're going to approach them both the same, and you're going to do your assessment both the same, but you're looking for specific injuries based on that pattern. The other thing with the pediatric patient I would consider would be ligamentous injuries, because remember, they're more flexible with their bones, so you're going to see injury without fracture a lot of times. So keep that in mind as well, because we don't want to miss those injuries. All right, so we're going to look at the ABC. So let's look at our assessment, our primary assessment. Okay, remember, primary assessment, we're looking for life-threatening injuries. What could be happening to this patient right now, both of these patients right now, that could be life-threatening? Okay, so we're going to do the airway, the breathing, the circulation, disability, and then exposure and environment. Okay, systematic approach to every patient every time, and you won't miss things. Okay, so with our pediatric patient, as we're considering the ABCs, okay, we're also going to consider our past medical history, okay, because that's important to know. I want to know a past medical history, and I want to know medications as I'm doing my assessment. A lot of times when you get pre-hospital report, they're going to give you those pieces of information, which is kind of nice to be able to have that ahead of time. It's kind of like cheating, but you get to have that, and that way it kind of helps you put the puzzle together, because that's going to lead me to believe, if they have this history, I'm going to be worried about this maybe, okay? So with our pediatric patient, she has no medical history, no surgical history, a healthy 5-year-old child. All right, with our geriatric patient, he has CHF, he has AFib, he has insulin-dependent diabetes, he has GERD, and he has COPD. Okay, so with those, that history right there, he takes DIG for his CHF, takes Xarelto for the AFib, takes a long-acting insulin, takes an antihypertensive and a beta blocker, and takes an H2 blocker, and takes a steroid inhaler for the COPD. So there's quite a history right there that concerns me greatly for the geriatric patient. Okay, so you have that information written down there for you if you need to refer back to it. Okay, so let's talk about our airway. So we're assessing our airway. With the pediatric patient, there's a couple of differences in the airway that we could get concerned about. It's more of a funnel shaped, it's short. They're at high risk for aspiration. And with our patient having no past medical history, as long as she's communicating to us, that's a good thing. As long as that child is crying, they have a patent airway. For that matter of fact, if the elderly person is crying, they have a patent airway too. All right, just remember, considering the level of consciousness can affect their airway, okay? So make sure that when you're assessing their airway, if they're becoming more obtunded, you're gonna be concerned that if they can maintain and manage and support their airway. With the elderly folks, they get a thinning epithelium, and they have poor dentition. So the poor dentition could result in an obstruction. So let's say they have some teeth that could become loose, get lodged in the airway. And then with a thinning epithelium, the intubation, if we have to intubate this person, they could be at risk for hemorrhage. So be prepared for a difficult airway if you have to intubate the elderly. All right, so with our breathing, I'm gonna move on to that now. The other thing that I wanted to just touch on, make sure you utilize your resources that you have. With pediatric patients, you want to grab that Broslow tape early. you want to utilize that, you'll see that this afternoon, and you'll be able to see how we use the Broselow tape. It's really a great tool. It has a lot of information, real easy to use that in comparison with the code cart, and you have everything you need in kind of one drawer. So it's a great tool. Don't forget to use that. All right, with breathing, excuse me, with the pediatric patient, diaphragm is their primary breathing muscle, so they fatigue real easy. So again, depending on the age of the child, we're talking about our 5-year-old, she's going to be more breathing normally like an adult would, but like an infant would be more of the diaphragm breather, okay? They have less O2 reserve, so they get early hypoxia. They sometimes have a higher respiratory rate, depending on the child. Remember, they're scared. They're in an unfamiliar environment. A lot of times mom and dad might not be there. Maybe they're on a longboard in another room and they're frightened, so the respiratory rate's going to be a lot higher too. And remember, these patients have a more compliant rib cage, so a lot of times they can have injury without fracture. Okay, so again, a crying child is a breathing child, right? With the elderly, they have altered alveoli, so they get poor gas exchange. And we know this patient already has COPD. So they're going to be already in trouble. A couple of reasons. So their lungs are already compromised. We have them lying flat on a longboard. So they may have trouble breathing, not necessarily because something's injured, but just because of their past medical history and because of the positioning that we have them in. So if we can put them in a reverse Trendelenburg, that may help them breathe a little bit better if they don't have any lung injury. The other thing is with elderly people, they get a stiffening of the lungs. Their lungs are old, and they get increased pressure to ventilate them. So if we do have to intubate this patient, then we may have some trouble into ventilating them just because their lung compliance is stiffer, not on top of the COPD that they already have. All right, so if the patient, the elderly patient, is obese or they have a large belly, laying them flat on a longboard may be problematic. So consider a reverse Trendelenburg if you can't clear their spine at that point. All right, so let's move on to circulation, because right now for our patients, we're doing okay in both of those areas. For circulation with the pediatric patient, remember your blood pressure and heart rate varies depending on the age of the child. So you'll have to make sure that you're aware of what your pediatric normals are. Most of our, the ED I know has it, so does trauma admitting, and I'm sure the PICU and the other pediatric areas have resources available to them. We have things mounted on the wall that give you normals for pediatric patients. Your Broselow tape is another tool to use to know what normals are for that patient, okay? Remember, they're smaller vessels, may be hard to get IVs in them. Go to your go-to people who are really good at them. The PEDS ED has been phenomenal to trauma admitting and allowing to help us get IVs when it's been challenging and difficult in our pediatric patients. They're really good at them. So use your resources, because you don't want to blow all those vessels if you have to resuscitate this patient, okay? Central lines could be in the future, depending on how sick the child is. They may do a central line as well. So keep that in the back of your mind that you may need to grab those supplies for that. All right, so what else with them? So they can compensate for a while. Pediatric patients are really good at compensating for quite a time. But their cutoff would be about 25% of their blood loss. So once they hit that point to where they've lost about 25% of their blood volume, they're going to plummet, and they're going to plummet really, really quickly. They compensate, and crash. So if my pediatric patient is doing really well and her blood pressure's fine, and she looks good, we're looking at the color, right? We want to see a central cyanosis. We want to make sure that they look good, they're not pale. And a good judge of volume, that they have a good volume and that they have good resuscitation, would be their urine output. So monitoring an INO, if you can, when that's possible. If they have good urine output, chances are they have good perfusion. Okay, it's really a good judge of that. And then with the adult, with this elderly patient that we have, we would expect a normal blood pressure, right? But we know that this patient also has a history of hypertension. So what's normal for that patient? So they may be hypertensive. Are they compliant with their medications? I'm going to assume they're not. I'm going to assume they're not, because if I assume they're not, then I'm going to be looking for more things, right? So what's normal blood pressure? So the American College of Surgeons, who again does our designation for trauma center, is looking at a number around a systolic of 110. If it's anything less than 110, that may not be enough to perfuse organs in an elderly person, especially someone who's normally hypertensive. If we make them a systolic of 110 and they normally run 160, 180 systolic, we're not perfusing those organs because that's not what their body's used to. So we may not know what their normal is, but you need to take into consideration anything less than 110, we're considering hypotensive in the elderly, okay? And that's over the age of 65. They also have vessel and valve elasticity. There's a loss there. They're not really flexible anymore. They're a little more rigid. So they don't respond well to shock states. And then they have thickened veins, so they get all that dependent edema. Also, we worry about their cardiac output, cardiac reserve. This patient that we have has a history of AFib, CHF, and hypertension. So they've got some cardiac issues already coming into play before we even get started. Okay. The other thing that we know about this patient, the elderly patient and the pediatric patient, both have gastric injuries, both have small bowel injury, both have large bowel injury, and the elderly person was diagnosed with a subdural. Okay, so considering all of those things, we have some work to do because both of these patients are at risk for hypovolemic shock. Okay, they're also both at risk for peritonitis, so we're going to be looking for infections. They're probably both going to have to go to the OR for an exploratory lab just because of the bowel contents and the gastric contents being in the peritoneum. All right, so we're going to anticipate both of these patients having to go to the OR. Now keep in mind with our circulation, we talked about the elderly person maintaining our systolic of at least 110. With the pediatric patient, we want to maintain a normal blood pressure. We don't want to allow them to become permissively hypotensive. So where we would in a normal adult who's in their 20s, 30s, 40s, we might allow them to be a systolic of 90 and maintain there if we think that they're hemorrhaging. But a pediatric patient, we do not want to do that. We don't want to make them hypotensive for any means, okay? So let me talk to you for a minute about the medications that the elderly patient is on, okay? The elderly patient is on anticoagulants, antihypertensive, and DIG. So what are your concerns about shock states with those medications? So what does DIG do? It does kind of make the heart work better, more efficiently, sometimes slows the heart rate down. So that patient will not be able to get tachycardic potentially if they're on a beta blocker. Beta blockers are huge because they completely block the ability of the heart to get tachycardic. So I can't see tachycardia in an elderly patient that's taken a beta blocker. So they may never get tachycardic. They may stay a systolic of 70. But when you're talking about shock, first signs of shock, your blood pressure is like one of the latest things you see. You're going to see anxiety, you're going to see tachypnea, you'll eventually start to see a tachycardia, then you'll see hypotension, and by that time we're heading to class 4 shock, and which could be irreversible. So you want to make sure that you're aware of what medications are on. If they're masking any of your shock states, keep an eye on the other signs and symptoms of shock as well. So again, with the elderly, just like with the pediatric, good urine output is good perfusion. Okay, now anticoagulants. So if this patient's on Xarelto, I don't know what you know about Xarelto versus Coumadin, but Coumadin has a reversal agent, and we can actually reverse Coumadin if a patient's on Coumadin. So I could give them some vitamin K, take a long time for the vitamin K to kick in and reverse it, but immediately we could give them some FFP, and that could help reverse the anticoagulant effects of the Coumadin. But Xarelto doesn't have a reversal agent. So some of those newer anticoagulant drugs don't have reversal agents, which is really tricky in trying to manage hemorrhage because they're just going to keep bleeding because I can't fix the problem. So be aware of your medications that your patients are on and know if it's something that we can help try to reverse if that need be the case. All right, so we're going to keep our eye on our blood pressure. We're going to monitor our blood pressure or vital signs frequently. In the trauma bay, we tend to take vital signs every 3 minutes until they're stable, and we do 3 manual blood pressures. We don't do by the machine. They're definitely manual blood pressures because the machines can always give you some false readings. So until I'm sure that I have a stable blood pressure, I'm going to do it manually. Highly recommend that. And just keep your eye on your urine output as well as part of that vital sign when that's feasible. All right, so we now are going to go to our disability. So looking at the disability part of this is where we're looking at our neuro assessment. Now we kind of have done a neuro assessment as we've talked to our patient, knowing that either they're coherent or not. But now we want to kind of look at those pupils and see what we're seeing. Now we know that the elderly person has a subdural, so I want to see what that looks like. How strong are they? With our pediatric patient, this is where we can find spinal cord injury. So we want to make sure we do a really good assessment neurologically. All right, so with the pediatric patients with disability, if they have a head injury, with the infants, you can see the bulging fontanelles. That could be a sign of an increased intracranial pressure. Their heads are bigger. They're more at risk for head injury. Sometimes they have thinner cranial bones, which makes their brain more at risk. And skull fractures as well. Now our patient, when she came in, was a GCS of a 3.35, which would be a GCS of 11. Okay, so anything less than 8, the patient can't maintain their own airway. So she's able to maintain her airway, but she's probably lethargic, not really fully awake, so I would be concerned that she had head injury. At that point, I would also do a pupil assessment, and her pupils were equal and reactive. Basically, her injury was concussion, so she was a little lethargic from the concussion and in a concussive state. With our elderly person, he had a GCS of 15, was completely with it, awake, alert, and oriented. Pupils were equal and reactive. Now, the thing you need to be concerned about with a patient with a subdural, especially an elderly patient who's on anticoagulants, a lot of times with the elderly, they, as you learned in your neuro lecture, their brains kind of shrink over time. And so the bridging veins tear real easily because they have that extra space. And that's what gives them that subdural. But they can compensate for that subdural for a really long time because of that extra space. So the blood fills up, and it takes a while before there's so much blood and so much pressure that it begins to affect their GCS. So with them being on an anticoagulant and with them being on having a subdural, I would be concerned to really do really good thorough neuro assessments, because at any point in time that neuro assessment could change and they may need to go to the OR for a craniectomy. With the elderly, they many times have a scoliosis or a kyphosis, where their spine is bent and curved. They don't sit on the longboard well. They may even rock on the longboard a little bit. So we want to get them off of the longboard. Same thing with pediatric patients. Their skin is very sensitive. So both of these patients have sensitive skin, so we want to get them off the longboard as soon as we can so they don't develop any sores or tears from the longboards themselves. Okay, as long as it's a safe thing to do, as long as they're cleared and are able to get off the longboard. All right. So a lot of times with our elderly people, they can't hear, they can't remember, they can't see well. So a lot of things that's going on, that maybe they're not following commands because they can't hear us. Same thing with the pediatric patient. You have to use a tool that would be something simple for them to use. Asking them who the President of the United States is to a 5-year-old may not know that answer. So that's not really a fair question. So, what's your mom's name, if you know that information, or, something about Mickey Mouse, or something that that they like. Make it a fair question for them to be able to judge whether or not they're able to follow and understand what you're telling them to do. Okay, a lot of times when they have patients have collars on and they have the CIDs, which are the blocks that go over their head, they can't hear because we've blocked their ears. So you may need to speak up a little bit for that reason. Maybe they can't hear you. So make sure that you're very clear in your assessment and asking the questions that you're asking them to get your assessment done, so that they have, you're getting the correct answers, not because they can't hear you and thinking that they have a head injury, but because they really don't have a head injury and we just weren't speaking clearly enough for them. All right. So this patient, our little 5-year-old, she has a L3 spinous process fracture. She has an L4 compression fracture. She has an L3 to 4 ligament disruption, and then she has an L2, 3, and 5 compression deformity. So she does have a couple of fractures. So the fact that she has some fractures means that was a pretty significant force when she crashed in that car. When I think about it in my head, having seen what the body does in car crashes, she literally would bend in half like a pretzel. If you if I were to sit on the floor and try to put my head between my knees, not only would that be funny, and probably not able to get up again, but I couldn't do it. I can't bend that far. A flexible gymnast probably could. Maybe some of you can. I cannot. But to have that force, and then force, if someone was behind me pushing me down and pushing me until I got to that position, would injure my back. So that's the same thing that's happening here. She had so much force in such a short period of time, it bent her in half more than her body really is able to do. So she's got ligamentous injuries, and she does have a couple of fractures. Our little elderly patient, he has a C6 teardrop fracture, and he has multiple compression fractures of L3 through 5. Now remember, bones are more cartilaginous in kids, more like dust in the elderly. Okay, so they're going to break much more easily. Compression fracture doesn't surprise me at all in a lap belt injury. Ligamentous injuries doesn't surprise me at all in lap belt injuries with the pediatric patient. Okay, so what difference does it make in these two? So the problem with the teardrop fracture, the C6, and the spine, and that level of injury, the patient hit their head, causing a flexion extension injury, probably bent their head back, hitting the seat in front of them as they were coming forward. So this gentleman actually ended up with a central cord injury, which is where, I know you guys learned about spinal cord injury, so I'm not going to go into a lot of detail about that, but it's basically where they can move their legs, but not their arms. I think of the dancers that just stand there and just move their feet and their hands are down. I forget what they're called. But that's what a central cord is. They can move their legs, but not really use their arms, okay? Now, our pediatric patient did not have a spinal cord injury. She just had fractures, and she had ligamentous injury. These are all, we can correct all this. This isn't something that's going to leave her with a permanent disability. She required a TLSO brace, which would be a brace to support her spine while she's up out of bed until the ligaments healed, and did well with her injuries. A spinous process fracture, basically, if you look at the spinal column, if you were to feel the back of your neck and feel all the way down, that bump that you feel, that's the spinous process. If that breaks, it's a stable fracture. It's not going to affect the spinal cord at all. So she didn't have spinal cord injury, fortunately, with her injuries. However, our elderly patient did, and if you see on the next slide, I showed you a picture of what a teardrop fracture is. It basically is a fracture of the body of the spinal column, and it also impinges the cord. A lot of times it shifts and causes an impingement on the cord, and that's where they get an incomplete spinal cord injury, which is your central cord syndrome. All right, so now let's expose our patients again. Okay, so now as we're going through this assessment, and I know we're doing a lot of these things all at the same time. And as we are assessing our patient, we are exposing. So we want to make sure we look at everything. We want to look at all her entire body. This little 5-year-old, we want to look at her head. I want to put my hands there. I want to see her chest. I want to see her back. I want to see her legs. I want to see her arms. I want to see all of these things. When I look at her belly, I'm looking for that seatbelt mark, right? And to which she did have, which is where we suspected the gastric injury and the hollow viscous injuries, the small bowel and large bowel. The elderly person, also, same seatbelt sign, worrying about those same type of injuries. So those are the things I want to see. It's going to make my mind go immediately to those injuries and suspect those things and start making sure that we're resuscitating where we need to resuscitate, okay? You want to warm the environment when we can. So if we know we have trauma patients coming in, we want to make that room warm. We want to make sure we have warm blankets available. As I said before, the triad of death, coagulopathy, acidosis, and hypothermia. We want to keep them warm. That's the best way we can protect our patients. So keep them covered. Once we expose them, cover them back up. And then log roll and get them off these boards as soon as we can. Because there's metal on them, some of them. They're cold. Get them off of them, make them comfortable when it's possible and when it's safe. Okay? And keep in mind, a quiet, calm child who would not developmentally be quiet and calm in this environment is probably in danger. Usually when a child is calm and cooperative, when normally you wouldn't think they should be, they're probably in danger. And that usually is the one that's going to decompensate very, very quickly on you. So while it's stressful to have a screaming child, that's the safest one to have because you know they're going to probably be okay. All right, but it's when they're quiet and calm that you really need to worry about the pediatric population. All right, so what's our secondary assessment? So our secondary assessment is where we're going back and doing a full, once again, head to toe, thorough evaluation. So now I am starting from the top of the head to the bottom of the feet. And when I'm looking at my pediatric patient, I'm talking to her and I'm trying to be calming to her, and I want her to trust me. And if we can get a parent in at the time, or someone who is able to, that knows the child and would calm the child down, that would be so helpful to you as the clinician. So we start at the top. We're looking for lacerations. We're looking for any foreign bodies, anything that would be of concern. We're feeling the scalp. We're feeling the face. I want to feel all the facial bones. I want to make sure there's nothing broken there. We're looking in the ears, we're looking in the eyes, we're making sure they can move everything. Smile for me. I want to see those cranial nerves are intact. I'm feeling the shoulders. I'm looking for fractures. I'm feeling, because kids are good about being so distracted. Sometimes they don't even realize that there's a fracture there until you touch it. So you want to palpate every extremity all the way down. Palpate the chest, palpate the rib cage. When we log roll them, we're going to look at their back. We're going to palpate their back. We're going to go all the way down to the bottom of their feet, and we're going to look for any other injuries that they may have. You want to go right for the axilla as well. Also checking in the groin as well. But again, make sure, because we're talking about pediatric patients, you want to keep them safe and you want them to be safe. You have someone else there with you when you're checking in the groin areas, okay? Any labs we need to do, any diagnostic testing. This is the point where if they need something for pain, we want to get them something for pain if they need it. And make sure that you consider the dosage, that it's an appropriate medication for that child and it's an appropriate dose for that child, okay? And then any adjunct therapy. If they need ice, put ice on it. A lot of times we forget about the ice. Something as simple as that is very pain relieving. Elevate it, right? Do those things if you can to help ease some of that pain and make the patient comfortable. Now with our elderly person, our little gentleman, again, head to toe assessment. Concerned about scalp lax with this guy. If he hit his head and he's got a subdural, I want to see his head. I want to feel it. I want to make sure there's nothing else bleeding. I want to look in his ears, feel his face, same thing, all the way down, head to toe, looking at every crevice, every corner, feeling, palpating, looking, and trying to make sure that we didn't miss any other injuries as we go. We were looking for life-threatening stuff the first time around, and now we're looking for secondary injuries that we may have missed. A lot of times with drivers of a car, they're driving and they crash their car, we miss thumb injuries because they were holding onto the steering wheel and the thumbs break. So it's easy to miss injuries, not life-threatening, but we don't want to miss it. We want to make sure we treat the whole patient. All right, so with our patient, so our little 5-year-old did really, really well. She ended up with some back injuries. They were able to repair the gastric injury. They were able to repair the small bowel and large bowel. Didn't even have to do any colectomies. They didn't have to remove any parts of her bowel. Were able to just do simple repairs. She didn't need any stomas or anything like that. Our elderly gentleman had a little bit more complications than she did. He ended up with getting a peritonitis. He also ended up getting an extending subdural and had to have a cranie done. Did not do well with the cranie, and they ended up withdrawing care on him, unfortunately. But the child was able to be discharged to rehab and within a 2-week period of time. So she did really, really well. And most kids do well. Most elderly don't. I mean, some could do great and they survive the injury, but he had so many complications and so many comorbidities that it really made such a difference with very similar injuries. You could see the outcomes were very, very different. Which leads me to our special considerations. So it's really important that in both cases we have open communication. With kids, it's always so hard because you think it's not fair. We put our emotions out there. A lot of times with the elderly, you think they've kind of lived a good life, right? So, but either way, you still have to have open communication. The families still want to know what's going on. Even with an elderly person who's healthy, they're always healthy. They work full time. I don't understand. They're not healthy. They're old. Unfortunately, their body just can't take those insults. So we need to have real good communication with the families to say this isn't going well, you know. And when things aren't going well, bring them in. It's okay, especially with the pediatric population. I think we're getting more comfortable with the bringing them in during resuscitations. We should be doing that with the elderly too. Anybody really, if the families want to be able to see that we're doing everything we can. Discussing long-term effects. So with a spinal cord injury, it's a long-term effect. We're not going to fix that. It's never going to go away. If the child had spinal cord injury, we need to talk about rehab. What's that going to look like? People think sometimes, and I've seen this happen, that because they go in and fix the spine is unstable and they have a spinal cord injury and they fix the spine, that they're fixing the spinal cord injury, and they're not, and they don't understand. And they think that they're going to walk again. So our communication, knowing what the long-term effects are going to be, is really important to discuss this and explain the term rehabilitation. What does that mean? Does that mean they're going to be back to where they were before they started? Sometimes it does. Does it mean that we're just going to get them over this hump and this is the best I can do? Sometimes that's it too. Sometimes they're never going to leave a long-term care facility, the elderly. That happens sometimes, but those are the types of information we need to have and conversations we need to have with the families so that they understand. Rehab to me means one thing, rehab to them may mean something else. So we need to be on the same page. And they need to be included in the discharge planning right from the beginning. Here's where we're going. Social work is great about including them in these things. I think we're getting better with our discharge planning, but it's really important that we include the family so that they have some discussion, they have some choices to make as to what the next steps are going to be. And the sooner the better. Also discussions of comfort care or withdrawal support. So in the case of our elderly person where they ended up withdrawing care, tough conversations to have, but in the interest of the families and what they thought was best for the patient, knowing that they were not getting any better, that was the decision. But the conversation has to come up and we have to start talking about it. And it's okay to say things like death, dying, they're not going to make it, this is unsurvivable. It's okay to say those things to patients and families. It's not always easy, but it needs to happen sometimes. Sometimes the physician will come in and say it and they don't get it, they don't hear it, they don't want to hear it, and then you come in and you say the same thing the physician just said and they just fall apart because it finally has registered. So that happens. That's what we do in critical care. Pediatric patients, really tough for a mom to let a kid go. Can't even imagine what that must be like. Here at Cooper, we have some great teams. Utilize your Child Life team. You have pastoral care, and you have the palliative care teams. And a lot of the pastoral care and the Child Life team are great teams here. They're amazing. Don't forget to tap into them. They're going to be really supportive of you as well as the patient and the family. And then if there's ever anything that there's of concern, there's always an ethics committee, and we do have that here at Cooper as well. So you can always tap into the ethics committee and say, I'm concerned about this, like they're not letting go and we're just really abusing this patient at this point. So know that you have those resources available to you as well. So don't forget to tap into them if you need them. All right, so that ends our discussion for the elderly versus child lifespan. And if you have any questions, just write them down for me and I will get you some answers. Thanks and have a great day.